Hello, good evening, friends. After continuously taking gynecology topics, I thought I should switch over to obstetric topic also. And this is a very, very important topic, both practically as well as from the exam point of view. In the recent advances, I saw a question on unexplained death at term, sudden unexplained death at term. So I thought we have to prepare the answer right now. So I'm taking this class for that purpose. Also, it is very important to know some very rare causes so that we can explain to the patient and patient party, and we will be able to convince them that things were beyond the control. Otherwise, it is very distressing for a lady who has gone through 9 months of pregnancy, and last minute, when everything was fine, she loses the baby. It is unacceptable. So let's look at the usual or explained causes of intrauterine death first, and the second part of the talk would be sudden unexplained or unexplored causes of death at term. Let's first be clear about the definitions. When we say intrauterine death of the fetus, it is death of the fetus after 28 weeks or period of viability, but before birth. Now, this period of viability differs from country to country, as you know. In India, we still consider 28 weeks is the period of viability, and I personally feel it's correct. Even though you may sort of save babies which have been born much before this, only to have some neurological problems later or sometimes cerebral palsy. 28 weeks is probably correct for our setup at least, because most of the hospitals are not well equipped to take care of the babies which are born before that. Whereas in the West, it differs from some places 22 weeks, some places 23, some places 24. Anything after that is considered period of viability, and that's why the death occurring after that period will be considered as intrauterine death. What do you call if there's a death before that? It is obviously a missed abortion or an abortion. Stillbirth is again a confusing terminology. Many people do not have a clear idea about the stillbirth and the intrauterine death. Stillbirth simply means no life at the time of birth. But why there is no life at the time of birth? Because the baby died inside the uterus. Doesn't matter even if it died in labor, but it died inside the uterus. Just before birth also it lost its life. That is also stillbirth. That means baby was still at the time of birth. Now, this is further divided into fresh stillbirth, which means the baby would have died within 48 hours before delivery, or macerated stillbirth, which means the baby would have died beyond 48 hours before delivery. So there was enough time for the maceration to set in. I hope this is very clear. Stillbirth is actually due to intrauterine death only. It's simply a different terminology, which means the baby was still at birth. Etiology, the traditional way of looking at it in obstetrics, is maternal, fetal, placental, and again, we can divide in different ways, medical or obstetrical or first trimester, second trimester, third trimester, whichever way. So here, when we talk about intrauterine death, I would like to classify it as maternal causes. All these causes can be summarized with one word. I always believe in understanding the subject in one word, and that is which causes placental insufficiency. So think of the causes which will cause placental insufficiency. The first thing that comes to our mind is, of course, preeclampsia or chronic hypertension, abruptio placenta. This is sort of acute on chronic situation, placental insufficiency situation. Diabetes. Yes, the placenta is big, but it is insufficient or inefficient placenta. Chronic nephritis. The placenta is shrunk and small. Hyperpyrexia, placenta will lose its efficiency. And syphilis, we all know, but luckily it has come down a bit now. Even severe anemia, not usual anemia, but severe chronic anemia can give rise to some sort of a plasma insufficiency in a way, and that can cause fetal death. Others, that is fetal causes, lethal congenital malformations, not the simple malformations. Because we know many fetuses are born with lots of defects, but these are very lethal congenital malformations. RH incompatibility is known to cause fetal hydrops and kill the fetus inside the uterus. There can be non-immune hydrops also. There is a big list of more than 20-30 causes. I don't intend to talk all of them today. Another day I will take a separate class on non-immune hydrops. That is also a long question. But today it is suffice to know this also can cause problem, because in non-immune hydrops, the cause may be again starting from the brain or intracranial area to the lungs, to the heart, congenital anomalies in the heart and the kidneys and in the GI tract. So all together, or even in the thyroids, there could be problems, and that can kill the fetus. Severe FGR, mild FGR may not kill the fetus. It may have certain problems, fetal distress, but severe FGR, long-standing FGR, early onset FGR, these are the ones which can have fetal death. Even late onset FGR, because you are caught unawares, you are not expecting the baby to do badly, and suddenly there can be fetal death. That is one of the causes of sudden, I'm going to talk about that little later, sudden term IUD. Iatrogenic, are we killing the fetuses? Not intentionally, of course, but when you do external cephalic version, inadvertently, there can be abruption, there can be snapping of the cord, there can be cord entanglements, and fetus can die. When you attempt amnioreduction, even in the third trimester, sometimes we may have to do as a treatment of polyhydramnios, especially in TTTS, then there can be sudden fetal death. Idiopathic, of course, this always completes the causes of any condition. Here also, we have to use idiopathic. What is the pathology post intrauterine death? Fetus undergoes aseptic destruction. As long as the membranes are intact, there is no possibility of infection. Very, very rarely there can be hematogenous infection. That's why aseptic destruction, what is called maceration, which usually goes through after the death. Blistering and peeling of the skin, which occurs within 12 to 24 hours. They'll be swollen, babies will be swollen, and they look dusky red. Liquefaction of the brain and viscera occurs. That's why there will be collapse of the cranium, and that's why there will be Spalding sign, which the bones will overlap each other, and viscera and lungs collapsing. That's why there'll be crumpling of the baby. The spine is bent on itself. Shrinking and separation of membranes and placenta. Whenever the baby dies, of course, the dynamism that is going through between the mother and the fetus is stopped, and that's why there will be shrinking of the amniotic fluid first, and then that will shrink the amniotic cavity. That obviously causes separation of the membranes and placenta as well, and we all know that when that happens, prostaglandins are secreted and she will get into labor. This is very important to understand, because whenever there is IUD, definitely the uterus will not keep the baby for a long time. It will definitely make sure that the baby is expelled or delivered. Something like what we say, when a dead body is thrown into the ocean, it will always come back to the shore. So similarly, the uterus will never keep a dead fetus inside because of this particular reason. There will be release of prostaglandins, and uterus will go into labor mode, and baby will be expelled. It may take somewhere between 1 week to 2 weeks, depending upon the patient and the condition that caused IUD. For example, if the condition was preeclampsia or abruption, then the uterus will get into labor very soon. Whereas if the death was due to a slow chronic reason, then the uterus may take 2 to 3 weeks. How do you diagnose? Of course, we diagnose by symptoms. The patient complains of decreased fetal movements or stopping of the fetal movements. Auscultation is not very clear, but the confirmation of the diagnosis is very, very important for us. Symptom-wise, yes, the absent fetal movements, as I just now said, or can be decreased fetal movements. Also, many ladies, even after the fetal death, they think that the baby is still moving. Most of us have felt that maybe the bowel movements and other things, or if they're just feeling that the baby is moving. Wishful thinking also sometimes make them feel that the baby is moving. But when we examine under ultrasound, we realize that the baby is not only dead, but it's been dead for a week or so. This is very important. That's exactly why, if there is one thing that the mother can help us, is being very, very sure about the fetal movements. And that's what we always tell. If she comes after the fetal movements have stopped, we can't do anything. But if she comes when the fetal movements are decreased, we can do something depending upon the gestational age and things like that. So after 28 weeks, we must spend some time, 20 minutes, 25 minutes, and explain to the patients the importance of fetal movement, number one. Number two, how to maintain the fetal movements. There are two main methods. Number one is cardiac count to 10, wherein it is 210, TO10. That means you ask the patient the time taken for 10 movements. It's something like, what's the time taken for running 100 meters? It may be different for different babies, but a given baby should take the same time, almost same time every day. For example, if the baby has taken for 10 movements today 1 hour or 45 minutes, tomorrow also it should take 45 minutes. The day it takes more than that, 2 hours for 10 movements, that means the baby is not doing well. Something like when we are not well, we don't feel like running, we don't feel like walking. So that is one method. The other method is that Sadowski's method, wherein you ask the lady to maintain 3 times a day fetal movement count. Here, instead of the count, the time is fixed. Morning 1 hour, afternoon 1 hour, and night 1 hour, preferably after a meal or eating something. And the movements can be any number. Morning 1 hour, usually we experience says that 5 to 6 movements, afternoon 5 to 6 movements, night also 5 to 6 movements. Then she has to start and finish at the same time every day, because the baby has got a sleep-wake cycle. If you keep on changing the time every day, then you will wrongly conclude that the baby is not moving or moving. So suppose she starts at 8:30 today morning, tomorrow also she should start 8:30, day after tomorrow also 8:30. Similarly, afternoon 1 o'clock or 1:30, whichever time is comfortable to her, but she should stick to the same time. And plus minus 1 movements are okay, but if there's a gross decrease in that particular time, she should immediately alert at that time only. This I spend every time when she comes for antenatal checkup, I keep telling them. That is very, very important. This is the cheapest and the best. Ultrasound is not required. Electronic fetal monitoring is not required. And this has got a positive predictive value of 50 to 60%. It is much better than NST, which is only 20%. So if the movements are decreased in the morning, she should immediately come to the hospital. She should not wait saying that it may improve in the afternoon or in the night. So that is very, very, especially in the night. When it comes down, they will think that why disturb the doctor, let me go tomorrow. Or they may say that the vehicle is not there. Especially at term, we should be very, very careful. We should plan the delivery. And that time we should tell them that, do you have a vehicle to come even in the midnight? So I can't overemphasize this. Fetal movements are the most important thing. Frank milk secretion. I have a story to tell actually. Once what happened, a lady came to Manipal and in the OPD, junior PG saw, she said everything is fine, and senior PG reconfirmed everything is fine. And the rule in Manipal is that even a staff should see, and staff also saw everything was fine. And then Usually by before admission, we used to say this happened long back. Those days, ultrasound was not very readily we used to do. But somehow we had an ultrasound machine in the department. And by the time the day's OPD was over, we would do the ultrasound of the ward patients. And that day, somehow it was so busy, ultrasound was not done. The next day, ultrasound was done. And another doctor, faculty said there is an IUD. Now, what to do? All the three people have cleared that there was everything was fine. But then when they called me to reconfirm, I saw Spalding sign. That means the baby has been dead for more than 1 week. Then I asked the question to the lady. She said, I had milk secretions since last 1 week and the fetal movements were decreased for 1 week. So that's how we could correlate and we could convince her that the baby's been dead for a long time. Otherwise, what happens? The patient will blame the hospital that everything was fine till I came to the hospital. After I came to the hospital, the baby died. The Spalding sign, which we could elicit in the ultrasound, is the one which really we could convince the patient that it's not after the admission the baby died, the baby must have been dead. And the only symptom she had was a frank milk secretion. So what I request all of you, all the PGs especially, is that if you are not very sure that you have not heard the fetal heart rate, please tell that. Don't say I heard it. The same thing I tell the senior PGs. Then when I asked the faculty, why did you clear? She said that she was a senior PG. She's most trustworthy PG. So when she said I heard the fetal heart rate, I didn't hear, but I believed her. So this should be avoided. We should be very careful. We should always be sure that what we have heard. Nowadays, of course, such things won't happen because most of the time, if we have a doubt, we use either Doptones or ultrasound. Signs. Uterine height is less than period of gestation, but then there are other situations where you can have this also. Or sometimes if the baby has just now died, the uterus may still correspond to the period of gestation. So this is maybe undergraduate teaching. Unless the baby has been dead for more than 2 weeks, you won't find the uterine height to be less than PVOG. Fetal movements are not felt, not only not appreciated by mother, you also, when you put your hand on the tummy, we have to do that actually. That practice has lost now. We don't really feel for the fetal movements and things like that. So we must put in hand for 10 minutes at least, or 10 to 15 minutes, and then we must feel the fetal movement. If we don't feel, that means there is some problem. And of course, when you auscultate either through stethoscope or the top tone, fetal heart sounds are not heard. During COVID also, we used to insist that the minimum that you have to do is a fundal height examination and the auscultation of the fetal heart rate. Other things, okay. The lie presentation and all that, you don't have to really spend much time, but the fundal height and the fetal heart rate, you should auscultate in every single checkup. Confirmation, as I said, in terms of Vidya Balan's statement, entertainment, I say ultrasound, and ultrasound, because nothing short of seeing yourself that the heart is not beating and showing it to the patient sometimes, if she can, tolerate that, is better, because otherwise it will all be very, very clumsy and you will not be able to take a proper decision. I want to emphasize this because, when the patient complains of decreased fetal movements, when you go for evening rounds or even morning rounds, I ask the PG, what will you do? The usual answer is, I will do an NST. The answer is 100% wrong. Why it is wrong? Because NST, if you want to do NST, you need movements, isn't it? What is NST? NST is nothing but correlation of the fetal heart rate with the fetal movement. So with each fetal movement, there will be increase in the fetal heart rate, acceleration of 15 beats per minute lasting for 15 seconds. That's a reactive NST. So when patient is saying that there is no fetal movement, why do you waste time in doing an NST in the ward? Immediately shift the patient to labor room where there is an ultrasound always available. In fact, we have 2 ultrasound machines in Manipal, and do an ultrasound first and make sure that the fetal heart rate is there. If the fetal heart rate is there, then count the heart rate. If it is normal only, Then go for looking for fetal movements by ultrasound, then go for Leica, then do a quick, these two are actually good enough, but you can also do a BPP, then show the patient that fetal heart rate is there, fetal movement is there, and reassure her. That is the right thing to do, not NST. NST you may do later, once you are sure of the fetal movements. Absent fetal heartbeat is the confirmation, nothing like that. In addition, if you want to make sure whether it's a macerated fetus or not, you can look for Spalding sign, that is overlapping of the cranial bones, hyperflexion of the spine, as I told you, because of the collapse of the lungs as well as the GI or liquefaction of that, crowding of the ribs, that is because of the liquefaction in the thorax, lungs, oligohydramnios or anhydramnios, because the liquor is not being circulated now through the fetus, fetal urination or swallowing or sweating and things like that. And retroplacental clot if the cause of IUD was abruption. What are the investigations to be done? This can be categorized. Don't write random answers like UGs. PGs, you must write categorized answer. The investigations to find out the cause of IUD, HbA1c, FBS or PPBS or better would be GTT, because diabetes is a big killer of the fetus. All preeclampsia investigations like RFT, LFT, platelets, because we know that is another big killer. APLA panel, ACA, LA, APTT, CVT, and DRVVT. Karyotyping of the baby and parents. This will help us in counseling the patient for the next time. The second set of investigations or category of investigations, basically to manage a case of IUD. So routine investigation, of course, HB, urine, blood group type, VDRL, HIV, HbSAg. Weekly or twice weekly as the case demands, TCDC. Though the membranes are intact with a dead fetus there can be infection. That's a good nidus. Dead fetus is a good nidus for infection. Hematogenous infection can take place. So twice a week you must do TCDC and coagulation profile. There can be coagulation problems if the dead fetus inside. PT, APTT, platelets, fibrinogen, and FTP should be done. This is very, very vital, especially when you have to counsel the patient. Look here, let us wait for the spontaneous onset of labor. Because the myth or the problems with dealing with the case of IUD is that patients are highly impatient. Once the fetus is dead, they want to get rid of that as early as possible, as soon as possible. So they will put so much pressure on the doctors that, doctor, why are you not taking care of? They in fact say, do a cesarean section and get the baby out. And it is, according to me, unless there is a big baby or a CPD or things like that, it is not proper to do a cesarean section for a dead fetus, right? So what are the complications? Infection, as I just now said. That's why TCDC should be done twice a week. Coagulation disorders, again, twice a week. Uterine inertia, whenever there is IUD, there can be infection and there can be uterine inertia. Retained placenta. The placenta gets incarcerated and that can be retained placenta. PPH. Again, uterine atony can lead to PPH. Subinvolution of uterus for the same reason, infection and atony. Puerperal sepsis. A dead fetus has been there for a long time. Psychological upset, obviously. So how do you manage? As I said, expected management is actually better, because in 80% of the cases, spontaneous expulsion occurs in 2 weeks. So we must have patience. We must have patience to explain to the patient, and we must tell the patient to be patient. So counseling is utmost important, because if you start doing something in between, you will land up in doing an unnecessary cesarean section. While waiting, you may do TCDC and coagulation profile twice a week or sometimes even alternate days. Earlier interference only if there is tendency to prolong beyond 2 weeks, or the fibrinogen levels are falling, or if there is evidence of infection or chorioamnionitis. I have taken a class on January 1st on chorioamnionitis. If any of those signs, temperature or TCDC going up, you can consider interfering earlier. Psychological upset. Sometimes the lady is so depressed, and sometimes she is so inconsolable, then you may have to take a decision to interfere. Some favor routine early induction, which I don't subscribe at least. I would rather convince the patient to wait and tell them in different analogies, saying that, when the fruit is ripe, if you just touch it, it will come in your hand. Otherwise, you have to cut it, you have to tear it and things like that. So when it is time for the uterus to go into spontaneous labor, just giving 1 to 2 tablets of misoprostol, she will just expel. So we have to have patience. We have to tell the patient properly. I hope I'm very clear and I've convinced all of you. So how do you induce? ARM is contraindicated. Why? The reason is very clear. It will give rise to infection, except in abruption, where it is a fresh death that has happened. And in abruption, the management is always active, and active management principle includes ARM. If the baby is alive and if there is no distress. If the baby is in distress, you don't even bother to do anything, you straight away take care of first section. So ARM is contraindicated because of fear of infection, as well as the other reason is that the bag of membrane will act like a head. The head is collapsed, especially, let's say, the bag of membrane will exert 360-degree pressure on the cervix because, as you know, cervical dilatation is depending upon 2 things. Number 1 is uterine contraction. Number 2 is 360-degree pressure exerted by the head. So the bag of membrane will act like a head. So don't do the ARM. If cervix is unripe, then PGE to gel 8 hourly for 3 doses can be given. But nowadays, we don't really prefer this because it requires a lot of cold chain and things like that. We prefer nowadays the misoprostol itself, 25 mcg, either sublingual, oral, vaginal, that is 4 to 6 hourly, 4 to 6 doses. I think mostly sublingual is the most preferred in Manipal now, because vaginal, again, you are introducing infection and things like that. Oral, sometimes patients will feel that we have to give more tablets. You may give oral mifepristone 200 milligrams 48 hours prior to inducing with misoprostol also. But all these things are done after 1 to 2 weeks after the recognition of IUD. So delivery, allow to expel on its own with no or minimal interference. If you try to pull, the things may come in your hand. Especially if, let's say, in the vertex delivery, if you pull the head will come in your hand, rest of the body is inside. If it is breech, you pull the baby's body is in your hand, head is inside. So similarly, don't pull on the placenta as well, because that will snap and there will be a problem. Vacuum is contraindicated with the Spalding sign. Avoid forceps in macerated baby. Again, for the same reason, head will come in the forceps, but body will remain inside. Don't pull on the cord. Allow spontaneous expulsion of the placenta. Watch for PPH. I told you already. Routine antibiotic is given. Prophylaxis is given. So now I come to sudden intrauterine death, okay, which is also called sudden intrauterine unexplained death syndrome. So practically, death occurring before labor with no evident maternal, fetal, or placental abnormality sufficient enough to be considered as the cause of death. So here we are stuck. There's no maternal problem, no preeclampsia, no diabetes, no nothing, major events. Placental abnormalities are not very obvious. There's no gross IUGR or FGR. There are no gross anomalies, yet the baby dies. It's a diagnosis of exclusion. Besides routine serum and serological tests, it is mandatory to perform autopsy of the fetus to know the cause, maybe intricate heart problems, maybe other problems. And gross and histological examination of the placenta should be done to see, again, intricate problems. This is the practical definition. But when we say SIUD, that is sudden intrauterine death syndrome, the definition says fetuses that die unexpectedly, particularly in the last weeks of gestation without any cause. It sounds the same, but there's a small difference. Even after a complete autopsy, including examination of the placental disc, umbilical cord, and membranes. That's the actual correct definition. It has a 6 to 8-fold greater incidence than that of sudden infant death. That is very scary. Why you call it syndrome? It is based on the observation that several conditions correlated with each other and occurring together may contribute to fetal death. That's what, after all, syndrome is, isn't it? What is pathogenetic mechanism? At this moment, not yet been determined, even if the neuropathology seems to be a consistent substrate in both SIDs, that is infant death, as well as SIUDs. Subtle common developmental abnormalities of brainstem nuclei, checking the vital functions, have been highlighted. This is to be proven. Abnormalities of brainstem nuclei related to environmental risk factors such as cigarette smoking, even passive smoking, air and water pollution. This happens in plenty in the cities. Food contamination, it can happen anywhere, cities and as well as in rural areas. This could be the problem. We never think of this. Exogenous toxic factors can also interact in complex ways with the infant genetic constitution, leading to polymorphism and/or mutations of specific genes. Unexplored causes, maternal causes, intrahepatic cholestasis. We always think that it is normal in pregnancy, nothing to worry. But if the bile acids are more, it can kill the fetus. Antiphospholipid syndrome. We would not actually check during pregnancy, thinking that pregnancy, we should not check this, but it should have been checked earlier. Inherited thrombophilias. We normally don't do this. It is done only in experimental situations like protein C or S deficiency, factor 7 deficiency, factor 5 laden mutation, mutations in antithrombin 3. What about unexplored fetal causes? Undiagnosed or missed anomalies. That's why autopsy is a must. Undiagnosed or a missed FGR or a late onset IUCR, which is more dangerous than the early onset, because in early onset, at least you are following the baby and you will take action in time. Whereas a late onset, you are suddenly caught unawares. Late onset FGR. Fetuses between 11th and 12th percentile. 10th percentile, we are very careful. 11th and 12th percentile babies, we think that they will do well, but they may not do well. Massive fetal-maternal hemorrhage. We did a thesis. I did a thesis through my student, and we found out that this could be the cause. Genetic defects, metabolic disorders. That's why in Manipal now, every baby will have a free inborn metabolic disorders checkup. Intrauterine infections. The placental and other cord accidents like prolapse of the cord or not true knots, very rare though. Entanglements, especially in twins. Cord anomalies, single umbilical artery, hypercoiling. We did again another thesis on hypercoiling will causing problems. Confined placental mosaicism and mutation defects and chorioangiomas. What investigations you would do? Fetal MRI autopsy is the minimum. After that, APLA panel, torch screening, because intrauterine infections can cause problem. Glycosylated HP, you would have missed diabetes, Cure bed case test, massive hemorrhage, karyotyping, and genetic studies. So what are the determinants? In elderly women, grand multi, consanguinity, infertile women, smoking, maternal blood group O, genetic testing is very important. What about determinants in previous pregnancy? If there was an IUD in the past, FGR in the past, preterm delivery, LSCS, and interpregnancy interval, short interpregnancy interval, we have to be careful. In present pregnancy, if there is obesity, multiple pregnancy, bleeding in first trimester, mild impairment of glucose, mild FGR, low normal AFI, and past date pregnancy, and suboptimal care. These are all very important. So what is suboptimal care in the labor? The 5 highest risks for obstetric harm that can occur during labor by Seton multidisciplinary work group is, I have told you this in another class during fetal monitoring class, inappropriate use of oxytocin. We have to do continuous fetal monitoring after oxytocin induction. Anything, oxytocin means oxytocics also. It could be misoprostol induction also. Failure to recognize fetal distress. Very, 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 very important. That's why I took a good length class in the intrapartum fetal monitoring. Refer to that class. Inappropriate use of vacuum or forceps, that can kill the fetus. Failure to perform timely cesarean section. Many deaths occurred because of this, and we don't know where to hide our face after that. And finally, failure to properly resuscitate a depressed baby. So this, take a screenshot of this. These are the 5 important things. I always teach this to all the PGs. So what is Oxytocic Bundle for obstetric case? Documentation of gestational age and estimated fetal weight. Examination of cervix within 1 hour of oxytocin. Ensuring that reassuring fetal status is always present. And absence or management of uterine hyperstimulation. Operative vaginal delivery bundle includes indications of instrumental delivery should be properly documented, estimated fetal weight, relative size to the maternal pelvis, presentation and station of the head should be documented. Intrapartum care includes strict adherence to partogram, refer to my second class. Continuous electronic fetal monitoring or intermittent auscultation every 15 minutes in first and every 5 minutes in second stage. Early detection of fetal distress, active management of labor with ARM plus oxytocin, timely and careful instrumental delivery, avoiding late cesarean section. I'm putting it in a different way. Other things, glycemic control in a case of diabetic, it should be between 72 to 126 every 2 hours. You are estimating the glycosylated sugars. Continue antihypertensives and anticonvulsives. Avoid sedation 3 hours prior to delivery. That will otherwise have neonatal impact. Deliver preterm babies by forceps. You may think that it will just come off why to use forceps, but you have to protect intracranial structures and prevent hemorrhage. Foresee and avoid shoulder dystocia. 1/3 of the babies in America die due to shoulder dystocia. Deliver second twin within 30 minutes. Otherwise, that baby is at danger. So this, all of you know, I don't intend to talk about this. That is the way we detect the fetal distress. Nice guidelines, it's almost the same in a different way. Prevent or avoid breech delivery by inexperienced obstetricians, internal prodalic version by untrained obstetricians, difficult vacuum or forceps, sequential instrument, no, no, no. What do you mean by if forceps fails, don't use vacuum. If vacuum fails, don't use forceps, take a first section. Obstructed labor, avoid at any cost. Shoulder dystocia, prevent or avoid. Thank you very much. I hope you understood this and you can write a good answer in the exams. See you tomorrow with another talk on maybe IUD itself, that is single fetal demise, what to do after that. And day after tomorrow, Dr. Pregna is going to give a guest lecture on pathways to parenthood. Thank you very much.